Welcome back to 2-Minute Anesthesia in Critical Care. Today let's discuss growth hormone physiology and the use of Octreotide in ICU. Firstly, we're going to discuss the basics of growth hormone physiology involving the hypothalamic pituitary axis. Growth hormone is secreted in pulsatile bursts in response to a range of factors including sleep, stress and hypoglycemia. Its release is regulated by two key hypothalamic factors. These include growth hormone releasing hormone or GHRH and also growth hormone inhibiting hormone GHIH, also known as somatostatin. So growth hormone releasing hormone is produced by the arcuate nucleus of the hypothalamus. It stimulates the anterior pituitary, the AP, to release growth hormone. Conversely, growth hormone inhibiting hormone is secreted by the periventricular nucleus of the hypothalamus. It's a peptide hormone that acts universally as an inhibitor, binding to somatostatin receptors, SSTRs, on target cells to suppress the secretion of cellular activity, including inhibition of growth hormone from the release by the anterior pituitary. Broadly speaking, growth hormone acts as a metabolic builder. It promotes growth indirectly through the action of insulin-like growth factor IGF-1 and also directly by mobilizing energy substrates. Growth hormone stimulates lipolysis by activating hormone-sensitive lipase, releasing fatty acids and glycerol for energy. It also raises blood glucose by reducing insulin sensitivity and promoting gluconeogenesis, ensuring adequate fuel for the brain and other tissues. At the same time, growth hormone enhances protein synthesis and reduces protein breakdown, contributing to muscle growth and tissue repair. Note, these metabolic effects are system-wide. So within the bowel, growth hormone will aid absorption of nutrients by a range of effects including enhancing mesenteric blood flow, stimulating mucosal growth, and also enhancing absorption of nutrients. Now let's discuss a key pharmacological agent which can manipulate this pharmacological system. Octreotide is an agent which can mirror the effects of somatostatin, hence it's known as an analogue. Analogues refer to a drug that shares a structural or functional similarity with another. So Octreotide and somatostatin have a similar but not exactly the same structure, and therefore administration of this agent will lead to a reduction of growth hormone levels within the body. So now let's discuss the somatostatin receptor. So what binds this? Either somatostatin or analogues of this agent, i.e. octreotide. These are G protein coupled receptors. There's 5 different known subtypes, 1 to 5. Number 2 is the most abundant and number 5 is the second most abundant. Number 2 is expressed in a range of tissues, pituitary, pancreas, GI tract and the CNS, and therefore binding has a range of widespread systemic effects. It leads to the inhibition of adenyl cyclase, therefore reducing the levels of cyclic AMP within the cell, leading to downstream inhibition of hormone secretion, i.e. reduced levels of growth hormone. There's also the activation of potassium channels and also the inhibition of calcium channels. This hyperpolarizes the cell membrane, making it less excitable and therefore reducing the secretion of hormones and neurotransmitters. Now let's discuss the common conditions which present to intensive care which can be managed with octreotide. It's important to remember that the growth hormone is a building hormone promoting the uptake of key nutrients and suppresses anabolic processes such as protein synthesis, fat mobilization and also tissue growth. Since growth hormone stimulates growth metabolism, octreotide or other somatostatin analogues essentially oppose these effects. For example, in variceal bleeds, octreotide will reduce portal pressure, splanchnic flow, and therefore aid treatment. Pancreatic fistulas, which can reduce the amount of pancreatic enzyme secretion and therefore aid treatment. Intracutaneous fistulas, octreotide can reduce GI secretion and therefore fistula output. In carcinoid syndrome, octreotide reduces gastrointestinal activity, inhibits the release of multiple hormones including 5-HT, helping to control the symptoms such as flushing and diarrhea. In chylothorax, the exact mechanism of action is not fully understood, but may involve decreased intestinal absorption of long-chain triglycerides, which are a major component of chyle, reduced splanchnic blood flow, therefore decreasing lymph production, also slowing gastrointestinal motility and fat absorption, and thereby reducing the volume of chyle formed by the intestinal lymphatics. These effects are collectively lower the flow and pressure within the thoracic duct or injury, and thus facilitating healing. Now let's discuss the key pharmacological properties of octreotide. As we've discussed, it's a somatostatin analogue, has a range of uses, can be presented as a solution for injection or tablets. It has a range of actions and can be given via oral route, IV, subcut, or IM. The dosing is variable and should be discussed with a pharmacist. The systemic effects are broad and can lead to bradycardia, nausea, abdominal cramps, diarrhea, hypoglycemia, hypoglycemia, and hypothyroidism. Oral absorption is relatively poor compared to subcut, with high protein binding of 65%, a volume distribution of 13 litres per kilo. It undergoes hepatic metabolism and elation in the urine and via the liver.